first of all, I think it's great that we see an overall survival benefit. It's really a targeted regimen because we select the patients by the PI3 kinase mutation in the tumor or in the liquid biopsy, and we add a CDK4/6 inhibitor and we add endocrine treatment. So it's really a triple targeted treatment, and therefore I think this is great, and we see an overall survival benefit, which we want to see because in many other trials we have never seen an overall survival benefit. But there is of course some caveat, and this was discussed also here at the meeting, that the crossover to another PI3 kinase inhibitor as second or third line was not 100%. I think about 25% overall got a PI3 kinase inhibitor in the control arm, and as a first treatment, I think it was 10% at second line. So I think taking that into account, we still have a very good overall survival benefit, but sequencing treatment, as for HER2-positive breast cancer, is very important. And my opinion is give the best treatment first, because you want to have the best long PFS, and then you need hopefully have new treatment options for your patients. This is a very interesting and I think today a difficult question, because monochemotherapy is not the standard of care anymore, at least in second and third line. Personally, this is my personal opinion, and actually monochemotherapy is not so bad. It has a bad reputation, but actually monochemotherapy like capecitabine is very well tolerated. And I think this is not so meaningful, but we have this endpoint because historically, and we look at that. Maybe we should look today time to ADC or to first cytotoxic agent involving ADCs as well, because in general ADCs have more toxicity than monochemotherapy. Inavolisib is probably the drug with the most potent and most purest PI3 kinase inhibition, but and this is certainly key, but we don't have any data in second or third line, which we have for other PI3 kinase signaling pathway targeting agents, to compare how the drug is. Although you never should do cross-trial comparisons, but for now it seems like this drug is really working very well, and the mechanism of action you just described is the key to the success of the drug. So toxicity, especially hyperglycemia, is the key toxicity. We have hyperglycemia, diarrhea, stomatitis, and rash. And I think for inavolisib, hyperglycemia is the toxicity. So I think selecting the patients based on their fasting blood sugar level and also looking at the HbA1c is very important, and also looking at the BMI of the patients to select those out who have a high risk for developing hyperglycemia and diabetes. And the majority of patients, actually almost all patients with hyperglycemia, receive metformin, and this is also the key drug. And there is thinking ongoing if we should give metformin prophylactically. And there was also a study presented here at the meeting in pre-diabetic patients, and they of course had a higher rate of hyperglycemia, but I think they could be managed very well. And I think we need to very carefully try to use this drug, but be aware of the side effects, especially hyperglycemia, and also need to inform the patients about that. Well, with the INAVO120 study, we need to be aware that we need to test the patients at first line. We have never had a drug where we need to know the mutation in first line. So I think for the future, we need to be aware that if a patient comes in, has a metastatic breast cancer in hormone receptor positive, HER2 negative disease, then we need to test for mutations. And to be complete, I think we should test for all mutations, and also including BRCA mutation. We should look for the whole signaling pathway, and ESR1 as well. Also ESR1 in first line is still low because this is an acquired mutation, but we need to change our thinking and need to test the patient and the tumor for their mutations.